Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hey everyone, welcome back to Cardiovascular Matters. A few months ago, maybe a month ago, we reported on a really interesting new technology for the treatment of hypertension. Up until just recently, if you had hypertension, you basically started on, the first thing you do is a healthy lifestyle. But for most folks, it was, starting on medications. And then a couple companies have come forward with some very interesting technology that basically can alleviate hypertension to the point where you may get off of all your medications and certainly down to just maybe one or two at the most. And people think, well, one or two meds, that's a lot. Well, it's not a lot if you're taking 5 or 6 and you're still uncontrolled. So anyway, I wanted to circle back with Dr. Walker on this topic today because there's been an exciting announcement that's going to make this technology readily available to everyone out there. Dr. Walker?
Sure. Well, Terry, the big announcement was that has come out is that Medicare and CMS have agreed that they will pay for the procedure called renal denervation.
Fantastic.
So let's understand why this is important. High blood pressure means that the pressure within our arteries is higher than what are considered normal values. And why is that important? Well, the heart is a muscle, and as this muscle has to strain against high blood pressure as it squeezes, because wherever that blood pressure is, the heart must exceed that blood pressure in order to push blood out of the heart into the arteries to go downstream. So what happens, one of the things that happens is the heart becomes thickened. The heart muscle becomes thickened, the major pump. We call that left ventricular hypertrophy, but it's a problem. Just like if I worked out with weights, my muscles get bigger. Well, if the heart works out against this resistance, it gets thicker. But the heart, on the other hand, is a pump. And any pump, before it can pump, must first fill. Well, if we make it twice as thick, it's much harder to fill. And so that's one problem. Secondly, high blood pressure results in arterial injury. So it increases the risk of developing blockages within the heart or blockages within the arteries to the brain, which can lead to stroke, or blockages in the arteries going to our legs, which can lead to amputation. In addition to that, long-standing high blood pressure can injure the kidney and lead to what we call nephrosclerosis, which is a cause of many people having to go on dialysis. So certainly, we have to treat high blood pressure because it increases our likelihood of heart attack, stroke, congestive heart failure, limb loss, all sorts of medical problems, all of which are huge. Now, you've mentioned we start off with lifestyle. We want weight reduction, low sodium diets, but many people simply are not controlled with that. In fact, many patients are not controlled with as many as 5 and in some cases 7 medicines.
Wow.
And certainly whenever we get beyond 2 or 3 medicines, there are often a lot of side effects. Well, there's a technology that was developed called renal denervation. And in this, we can use devices which we use through a needle stick in an artery. And within a very short procedure, we can actually affect the nerves that run on the outside of the kidney arteries. And what does that do? Well, that lowers blood pressure. Okay, and several studies have confirmed that this lowers blood pressure significantly. In fact, it lowers it at least as much as the strongest blood pressure medicine known lowers blood pressure. Now, this is very important, and I think more important than people realize, because many patients say, well, their blood pressure is just white coat syndrome. Or they'll come into a doctor's office and say, yeah, I just didn't take my medicines this morning. But we all know that when you're taking medicine, sometimes you forget to take a medicine. Well, if you have an intervention such as renal denervation, you can't forget it. Okay, it's done one time, and it gives consistent lowering of blood pressure. And, for me, I think in the future, this is something that could be done actually even in earlier patients with hypertension to avoid the escalation of blood pressure, because high blood pressure begets higher blood pressure because of its effects on the kidneys and other things. But even without that, some of the early studies suggested this might really help with heart failure and other issues. More data is needed there, but suffice it to say that the studies clearly showed that renal denervation can lower blood pressure. And, often blood pressure medicines have side effects. Patients, for instance, some of the most commonly used drugs are diuretics, but some of these, if people have sulfur allergies, they can't take. Or many people have photosensitivity with these. Chronic cough is another side effect of many of the blood pressure medicines. Yo-yoing of blood pressure which is sometimes too high, sometimes too low, has been reported with blood pressure medicines. And so there are a lot of side effects to these medicines. Certainly we have to use them, because if we don't control blood pressure, that has catastrophic effects. But I'm very excited about what renal denervation may mean to many patients. Now, the problem we had before with renal denervation was not that it hasn't had clear benefits in all of the trials. The problem was there was no payment for the procedure. So a procedure has been approved, and now CMS has announced that starting in January of 2025, there will be payment. I suspect, like most other procedures, once that occurs, private insurance will follow in quick motion. And I think this means a lot, certainly to my patients who are on many antihypertensive medicines, many of whom know they have to take the medicines, but have a lot of side effects on those medicines. I suspect it will be very helpful there. I suspect even more helpful to that group of patients that I have on multiple medicines, which costs a lot of monies over the years, but not only that, have these side effects, and to be able to come off of some of those medicines, that this could make a major difference. And I wonder yet if in the future we may not be addressing some of the earlier cases of blood pressure elevation with this. It is not approved for that at this point in time, but I fully suspect that may occur once we can demonstrate that this procedure is not a terribly dangerous procedure. It can be done effectively, and it does result in blood pressure being controlled much better. I think this may be a game changer in our ability to treat one of the greatest healthcare problems in our country and throughout the world.
I love it. So right now, who's able to receive this technology?
Yeah. Well, right now, there's still other companies looking at new devices, but I think the first two devices to gain FDA approval and to now have, as of January of 2025, coverage are Medtronic's device, the Sympathetic device, and Otsuka's device, the Recor device. They use different means. The Recor device uses focused ultrasound and a cooling balloon that heats up the exterior surface or the outer surface of the artery, which allows the nerves of that to be destroyed. The other device is actually a catheter that uses heat at the tip, which is created by radio frequency. And one makes spiral burns on the inside of the vessel, which affect the nerves on the outside. Now, in the large trials, these did not result in any injury to the kidneys. In fact, that was not seen in the trials. That was one of the concerns was that it may do that. And really, it's a procedure that's fairly simple for the doctor to perform. Now, when we're actually performing the procedure, the patient has for, sometimes it depends upon the procedure being used, but somewhere between 8 and up to 30 or 40 seconds of discomfort when you're doing it. But outside of that, really not a lot. And it's a one-time procedure that results in improvement in our ability to control blood pressure. I think this is going to have huge implications going forward because I think the concept of having to take medicines once, twice, or 3 times a day for all of your life versus being able to do something like this and maybe not need medicines at all, but if one needs medicines, limiting that to 1 or 2 that could be taken perhaps only once a day certainly improves our ability to treat high blood pressure. And it's awful hard in the trials. That the biggest dilemma in the trials was designing trials to ideally show how much it reduced the blood pressure. It was not considered ethical to really stop one's blood pressure medicines. So many of these patients were on blood pressure medicines, had to be, and actually during procedures, even with the procedures, many had their medicines either increased or decreased. And so it was difficult to get a good control group and a good treatment group just to prove how efficacious the treatment itself was.
Yeah. I think they also, some of the trials designed were taking the absolute just most critical patients and then rolling them in for the procedure. And so many of them did get help, but sometimes, you're past the point where you could really impact someone. And I think that was really tough on some of the trials as well. But I want to circle back for just 1 second, just so the audience understands, this is not a pharmacological approach where you're trying to offload fluid or something like that to lower pressure, but basically this blocks a nerve signal to the brain. Is that correct?
That's right. What you're doing is you're permanently destroying the sympathetic nerves that lie on the outer layer of the kidney arteries. These sympathetic nerves do have feedback with the brain, and the brain controls a lot of our blood pressure. In fact, when people have stroke, often blood pressure can go up very, very high because of this sympathetic control. So now you're blocking that. Now, there were concerns early on, would that result in injury to the artery? It did not. There were concerns of would people feel worse with this? Would it affect blood pressure in such a way that they would have a lot of side effects? That did not pan out. And towards your point before, I think we really want to get to high blood pressure before it's already affected our end organs, before our heart becomes real thick, before our kidneys are destroyed, before our arteries are damaged from the constant high pressure within them. And I could see this being something that is done earlier. And it's really quite simple. We access an artery, typically in the leg, in the upper leg. We actually then place a catheter, a fairly short catheter, about maybe 1.5 feet long or so. The catheter is into the kidney artery, and this device fits inside of that catheter. And we then do the treatment. Following the treatment, this typically takes 20 minutes or something like that. Following the treatment, the catheter is removed, and we apply pressure to stop any bleeding in that artery. And the patient goes home typically that day.
Right.
I think that this is going to be revolutionary in our
too.
ability to treat high blood pressure.
I do too.
And I suspect, like so many therapies, we'll see this move over time and be used earlier. The best example I can give is the treatment of aortic valve stenosis. When the first TAVRs or percutaneous, those devices that we would use to put in from an artery rather than open surgery were performed, it was only performed in people on death's doorsteps. And the results weren't so good. Then later on, it was performed in patients with very severe disease, and it performed very well, and it compared very well with surgery. Well, now it's being moved into people with earlier stage disease. At the most recent TCT, we were talking about that So devices come out, and often they're put in a box of only for that end-stage disease.
Correct.
But what we find is over time, as we look at this, the best place for those is in earlier and earlier disease. And I suspect this may go that way. We don't yet have approval for that. The approval is for patients who are on several medications and are not ideally controlled. And I think that's a good approval, and that's going to help us a lot as it is. But we'll see what happens over time. We'll see whether, as this becomes proven to be safe and effective in many patients, I suspect we're going to see this move to where we're using this in earlier stages. And frankly, from a convenience perspective, certainly having a treatment is a lot better than having to take medicines once, twice, or 3 times a day, in my opinion. As we look at trials, there are monitors calling patients to take their medicines once, twice, or 3 times a day. Those control groups usually do pretty good. When there aren't people calling them every day, oftentimes they forget to take those medicines. And we've all seen that in our own families, patients forgetting to take medicines. And certainly this could really help in our ability to better treat patients, in my opinion.
Well, it's exciting new technology. And you and I have both been around for a long time, and we've seen some these milestones. And I'd say this is one of them. Obviously, the invention of the coronary balloon back in the the 80s, and then on into the 90s, the stenting, and now this renal denervation, I think, is another huge step. Of course, all the statins and all the things that have come out to you've seen such a myriad of technologies and scientific breakthroughs that help patients, and this is one of them. I think we'll circle back here in a couple months and maybe even do a case presentation, kind of a before and after. Maybe we'll talk about their blood pressure before and their blood pressure now, and then kind of how they made it through that procedure. Probably went out and played golf the next day. So that's what I'd like to talk about.
I think that would be great, Terry. I have one patient that was on 7 medicines.
Oh, wow.
That is now only on 2.
That's the name of the game. And I think CMS looks at this from a standpoint of money, and a lifetime of medical therapy through pharmaceuticals versus a one-time procedure is a pretty good bargain. So I'm very excited to report more on this. I know that you're headed off to a big meeting either tonight or tomorrow to present, and we will circle back, and I'd love to hear about some of the things you've seen and learned since you get back from New York. But
great.
Thank you, everyone, for tuning in to Cardiovascular Matters. Be sure and like and follow us on whatever platform. That way you get notifications when we drop new content. We try to drop every week, but and we do the best we can. But like I said, Dr. Walker has got an incredible practice and travel schedule, and I like to fish. So we're gonna try to get 3 to 4 out a month, and certainly enjoy and appreciate everyone listening, and then certainly give us a thumbs up if you like the content. Thank you very much, and everybody have a great week.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.